in that moment, I couldn't fix anything. There's nothing that fixes that, but being present and being compassionate and, giving a hug. And I think sometimes in emergency nursing, we forget to see people.
Hello, and welcome to the Art of Emergency Nursing podcast. This is where we share stories for inspiration, entertainment, and encouragement because we all know emergency nurses have the best stories. Now, here's your host, Kevin McFarland.
Hey, everybody, Kevin McFarland here, and welcome back to the Art of Emergency Nursing. Thanks for joining me on the podcast today. If you haven't done so already, please take a minute and subscribe to this podcast to make sure that you don't miss an episode. For this week's episode, I have an episode I think you're going to really like. This week's guest is a longtime ER nurse, a forensic nurse, and now a nursing educator. She gets really deep in this episode and makes it really personal. I think you're going to love this episode. I really did. You're going to enjoy this episode with my friend, Liz Mezerek.
All right. Well, my name is Liz Mezerek, and I'm an emergency room nurse. I'm currently working per diem at a local community hospital. I also have a practice as a forensic nurse where I conduct sexual assault exams for the local prosecutor's office. And my full-time gig is actually as the director of nursing education at a community college. I am a certified emergency nurse, certified pediatric emergency nurse, and certified nurse educator. I like my alphabet soup credentials. I'm also a fellow in the Academy of Emergency Nursing and currently a doctoral student working on my PhD in nursing science at Widener University.
Didn't have enough punishment. The MSN decided you had to go for your doctorate.
I did not, but I have promised everyone that the alphabet soup will end. My business card has, one line for my name and one line for my credentials, and non-nurses don't get that, but nurses kind of get it, and I'm not sure when that need for all that alphabet soup will go away, but at some point, I promised once I get the PhD that'll be the end of it.
Then you're done.
I won't get any more.
Yeah, because after that, what else? Who else cares? They're going to be like,
yeah,
your PhD, and a, CE and
exactly.
TCRN. That's nice. Nobody cares. So I worked with a lady who's a little bit of a credential and kind of an academic snob. And she asked me one day, she goes, yeah, your office, you don't have any of your certificates or any of your, degrees up on the wall. And she goes, why don't you put that stuff on your wall? And I'm like, because in our organization and for my role, nobody cares.
Right.
and she was just devastated. The poor woman was just devastated. She was like,
well,
and I was like, for what I'm doing, nobody cares. Like if you work at a school, if you're the director of nursing education, you probably got to have that stuff up on your wall.
Right. And it's interesting because I kind of go back and forth with that, whether putting them up is intimidating to students or it gives them, something to aspire to, or does it give you credibility? Is it intimidating? Because the last thing I want to do is to be intimidating to a student. But on the other hand, when they look at my credentials, oh, you're an emergency nurse, then they all get excited because, lots of nursing students think they want to be emergency room nurses. And then I talk to them about what it's actually like to be an emergency room nurse. And sometimes I'm like, actually, you're an ICU nurse. You're not an ER nurse. So think about the ICU.
You almost wish you had something like in Harry Potter, like a sorting
hat.
Right,
sorting hat.
Put on a little sorting hat and be like, yeah, you're not an ER nurse.
Go
see our friends and sniff.
It's really funny because sometimes you can really see it. You can really see students, the ones who are incredibly detail-oriented and they want to know every little detail of the pathophysiology. I'm like, yes, ICU is for you. Go ahead. You will be very, very happy there. For the students who are like, I want something new every day. Squirrel. I'm completely distractible, but I like juggling lots of things. I'm like, come to our world. You are our people, you know. So you can sometimes really see it in the students, even from the very beginning. You can tell who's destined for certain things, and it's not always what they think it is, but in the end, we're frequently right. Not always, but frequently.
That's true. So I got to tell a funny story about you. And
Oh no.
I got a funny story about you, and I know I've told you this story, but I just want to share it with everybody else. So I first met you at one of the national ENA conferences. And I don't remember which one. It was one of the national conferences.
I think it was San Antonio.
It may have been. And I remember I was walking through the section where the states have their different tables. And I seen your name, and I remembered you because I had just cited you on a paper that I wrote. And I was like, this is the coolest thing. I'm meeting this woman whose paper I referenced, and it was I don't remember. It had something to do with paramedics in the emergency department. And I remember being like, ooh, look, oh my God, there she is. That's so cool. And just thinking that it was the coolest thing to meet the author of the paper that I just cited in my schoolwork. And I just thought you were just the coolest thing. And I was just like, I had a little bit of an academic, I'm like, oh, this girl's cool. So,
well, and on our end, I'm like, oh my God, you cited my paper? That's fabulous. Because sometimes you put stuff out into the world and you have no idea that anyone's reading it.
Yeah.
You think, okay, well, I put this out there, and I remember that article, and that article, it's funny, that's what we were just chatting about, is the sort of personalized orientation to understand that people coming to the ER are coming with different experiences, and that the standard orientation process might need to be adjusted for different people, because that was my background.
Yeah.
I was a paramedic before I became a nurse, so when I went into the ER as a new grad, I was really comfortable with things like cardiac arrest and trauma. That didn't scare me. A pelvic exam scared me. I had no idea what I was supposed to do in there, versus, cardiac arrest. I'm like, yeah, I'm good. I can defibrillate. I can push code drugs. I'm okay. I'm cool.
Yeah, you got that part.
Yeah.
Now, how long have you been a nurse, Liz?
I was trying to figure this out. I think 17 years.
Holy cow, that's a little while.
Yeah, and when I think about it, because I've always been involved in emergency care since I was 18 years old. As soon as I didn't need my parents' permission to join the local first aid squad, I joined up. So I was in pre-hospital emergency medicine from 18 to I don't know when, and then moved over to the inpatient side in the ER. So I feel like I've always been dealing with emergencies my entire life.
Why the transition to nursing?
Oh, so I swore I was never going to be a nurse. I didn't, I don't do bedpans, everything, all the stereotypes about why I'm not going to be a nurse. And then I met some really cool ER nurses, and I was looking at what they did, and I'm like, this is, I'd like to be able to do more. In New Jersey, paramedics at the time were pretty restricted in what they could do. They could only practice within the hospital confines. We had our list of medications, and you couldn't give anything that wasn't on that list. And I missed sort of the follow-up, the what happens next to your patients. And then there was the logistical reasons. I laughed when you were interviewing Andrew. He said, he came inside because he liked climate control, but that's actually a pretty strong driving factor. I worked nights. When you work nights and you go out at 2:00 in the morning and it's 3 degrees out and you can barely warm up your truck to go on a job. Like, yeah, being inside sounds really, really good. And I wanted to start a family. And I watched one of my coworkers who was very, very pregnant and sitting on the couch having contractions, and like, we got to go on a job now. And I was like, this is not a safe environment to be pregnant in. And I said, well, all things considered, maybe we should take a look at this nursing stuff. And once I got into it, I just knew that was right. That was the right call.
That's awesome. What's your favorite memory of being an ER nurse?
Whew. Favorite memory of being an ER nurse? That is such a hard question.
It's a hard question. We'll start with the hard ones, are they?
Yeah, that's awful. I guess the favorite memories are the things that are good and positive outcomes. And to be honest, we don't have a whole lot of those. We don't have, a tremendous amount where somebody comes in and we're like, hey, we're fixed. Oh, you have this? Let me, wave our magic wand and we fix you, and everyone walks out and they're happy. That is not the typical, ER experience. So, it's hard to come up with something that, we have funny stories. Oh Lord, we all have funny stories about like crazy things that have happened, and you're like, wow, that was cool from the perspective of, I got to learn something and try something new. I remember one patient who had come in and they cracked the chest in the trauma bay, and I was like, that's cool. Internal cardiac massage, that was not something that at the time was being done every day, and I got to see that, and I'm like, oh my God, that's amazing. That's their heart right there.
Like, look at that anatomy.
Like, wow, I got to do something really, really cool, or we got to deliver a baby, and that's not something that you do every day in the ER. You're like, that's awesome. But most of my memories are things that are cool for us, not necessarily always so cool for the patients.
Yeah, of course. Do you remember a patient that touched your heart?
Yeah, but I already told you I don't have a heart. So I thought about this question, ever since you asked me to come on. I knew that was one of your go-to questions. And I think about a scenario that I had when I worked in a trauma center where there was a car accident with lots of teenagers. And most of the teenagers were fine, but one was not. And the one was rushed into emergency surgery. And the problem with it was, and this scares the bejesus out of me because I have teenagers, is that no one knew how to contact her parents because she had come to us unconscious and so therefore could not tell us who to contact. Her friends had her cell phone. And I said, doesn't anyone know where she lives? At some point somebody's got to pick somebody up. She just moved. And so none of the friends had a parent cell phone number. None of them knew her new home address. So we had a town and we had a name, and that's all we had.
Wow.
And this girl was critical. And, coming from the mentality, of course, if this is my child or just any family member, you got to tell somebody. Nobody knew in her family what was going on. And so after she went up into surgery, actually before she went to surgery, I started making phone calls. And I literally opened the phone book, or not the literal phone book, the electronic phone book, and started going through everyone with the same last name. Thankfully, it wasn't a last name that was real common like Smith. So there was only 5 or 10 of them. So I just start calling all of them at, 2:00 in the morning. And whoever I'd get on the phone, I'd say, oh, can I speak to, so-and-so, using the girl's name, figuring that if I hit the house that she belonged to, they would say, oh, she's not here right now. Yeah. And so finally I got to a house and they're like, I don't know why you're calling for her, but that's my niece. And I'm like, bingo. So we finally got a family member. And from there we could then intertwine. We finally connected with the parents to get them there. Unfortunately, by the time the parents arrived, she was up in SICU and she didn't survive. Wow. And because I had been so involved with this situation, I was the one who brought the parents upstairs to that room that we put people in. And I had somebody from pastoral care with me. I did not know that the person from pastoral care, he looked kind of young. It was his very first night on call in the hospital. I found that out years later. And so we sat with the family in this room, and the surgeon came in, and went through the whole story of all the injuries and everything they tried to do. And at the end said something like, well, it just didn't work, but never said that she died.
Wow.
And you know how when people are in shock, they're just not processing. And sometimes you have to be really blunt. And he wasn't. And so we all knew what he was saying because we knew she was dead.
Yeah.
But then he walks out of the room and the family is like, so how long is she going to have to be in the hospital for?
Oh, God.
And that's when I realized they had no idea that the message he was trying to communicate to them didn't work. And so I had to be the one to tell them that this teenager was dead. And then we took the family into the ICU, and the ICU nurses had really kind of tucked her tightly into bed, pulled the covers very kind of tautly over her to kind of cover up everything.
Yeah.
And Mom was trying to crawl into bed with her daughter to hold her daughter. And this happened quite a few years ago, and I'm getting like a little teary-eyed talking about it. And I don't know how, but that pastoral care person managed to muster up the words to offer up some prayers. And we sat with her, and then we said, okay, it's time to go now. And we are so oriented towards fixing things.
Yeah.
All the time. That's what we do. We have a problem. We're going to fix it. We're going to stabilize it, and we're going to transfer it, or we're going to treat it or street it. And in that moment, I couldn't fix anything. There's nothing that fixes that, but being present and being compassionate, and giving a hug. And I think sometimes in emergency nursing, we forget to see people. I know you've talked before about the fact that, for the patients, it's the worst day of their life, right? And for us, it's Tuesday, right?
Yeah, you're right.
And I sometimes think that our biggest challenge is to never forget that it's not Tuesday to them.
Yeah.
And even for the people who come in for the things that are so obviously not emergencies, we have to acknowledge them. We have to see them as individuals. That sometimes is the nursing care that they need, is the acknowledgement of them as individuals and as somebody who's important. And particularly if there are those people that are at the sort of margins of society.
Yeah.
I just feel like we don't see people all the time, and that is the most powerful gift we can give them, and say, look, sometimes people come in, somebody came in like all kinds of serious because they had a serious vitamin deficiency. And I'm like, okay, so
let's get you set up for your primary care.
We're not going to be able to fix your vitamin deficiency tonight. We're going to do some basic blood work, and we're going to check everything out and make sure it's not impacting any of your other body systems. But, this is really, this is so complicated. I think you really need to follow up with your primary, and I was in triage. Sometimes I think the hardest thing to do is to keep a straight face.
Yeah. And
this was definitely one of those moments. But I really try to, every time I can, put myself in their place. I have friends who aren't in healthcare that they don't know. They get really anxious. They get a lab result, and sometimes the lab sends you, copies of your labs, and you see something that's deficient. And you're like, oh my God, what is that? And thankfully, I've got most of them trained to call me, and I go, no, don't worry about that. It's fine. It's normal. It's okay. Or that, maybe you should follow that up with your doctor. But I feel like a lot of times people just don't know, and they panic, and they come to see us. And we've got to be realistic with them. I'm not going to be able to fix that tonight, but we'll check you out, make sure there's nothing emergently going on, and we'll get you set up so you can get it fixed.
Yeah.
But sometimes just that being present, to me, I think it took me a long time to understand how important that is to people. And I think it was some of my own experiences being on the other side of the stretcher that helped me understand how important that is. Because they don't know. Families, patients, they don't know that you did something really cool, that you identified some weird EKG thing, or you caught a med error, or, they don't know any of that. They know how you make them feel.
Yeah, and they don't care.
And yeah,
You're right.
exactly.
You're right. Yeah, the countless people that, and there's countless patients, you probably have them. I think they're just ignorance is bliss, I guess. So.
For sure.
Sure. So. What is, hold on 1 second. I'm having a technical difficulty here. What do you think makes the difference between a nurse who gets burnt out in a couple of years and those who don't, and those who thrive in that ER setting?
Well, I think it comes down to expectations again. If you grew up watching episodes of ER on TV, or Johnny and Roy, if you really want to date yourself, you might think that the ER is like this super exciting place and you're going to save lives every day. And then you get that transfer patient from the nursing home who's covered in poop from head to toe and is septic, and you're like, this is not what I signed up for. I signed up for excitement. I signed up for trauma. I signed up to save people's lives. And turns out that no, that's not what we do each and every day. And so I think that's a big piece of it, is knowing that the work we do is important, but not always sexy.
Yeah.
And so that, I think, is a piece of it. Having sort of the good environment to work in as well, and learning how to not take things home with you.
It's hard.
I think is the hardest thing. Do you remember that show? It's a little bit older. I think it was called Rescue Me, about the firemen in New York City, and how he had ghosts that trailed after him, of like the little kid that he couldn't save from the fire. And I feel like we all have some of those ghosts that we carry along with us, about those patients that really something about them stays with you. But you got to learn on a regular basis how not to let I'm trying to think of a word that's not a curse word to describe the ER. The circus. The circus. That's not the word I was looking for, but the circus that is the ER some days, not to let it get to you.
Yeah.
And, I know a lot of nurses who work so many hours, and I think that contributes to it. I mean, a lot of people who are full-time, they work, they're 312s and they pick up overtime, or they have a per diem gig. But I know people who will work, 2 full-time jobs in the ER, and I don't think that's healthy.
Yeah.
And you don't get enough downtime to recover and realize that, everyone in the world is not like your worst ER patients, and that there's a whole thing of the world outside. There's sunshine and happy things to do.
Right.
And so people have to engage in some of those self-care behaviors. But, a lot of departments don't support that. They'll take you to work. Oh, you want to work 80 hours this week? Great. You have a pulse. You have a license. Go for it.
Yeah.
And nobody turns around and says, well, maybe this isn't a good idea. Maybe you need to, take a little time.
Yeah, it's important. It's important to be able to decompress a little bit. Not work, 100 hours a pay period. It's just crazy.
Well, and I think the other piece of that too is that we don't have enough mechanisms in place to support people when there is something that goes wrong. We've all had those codes or those situations. The patient's perfectly fine, and all of a sudden they crump on you, and you're like, holy cow, I didn't see that coming. And sometimes I think we have to acknowledge, hey, that was a messed up situation. And I know you're feeling like a certain way about it, and that's okay, because that was messed up. And I can't tell you how many times just walking over to somebody and saying, that was crazy. Can you believe it? And they go, yeah, I know. I thought it was just me. I'm like, no, that was crazy. That wasn't you. You didn't.
Not just you.
It wasn't just you. You didn't miss something crazy. I saw the same thing you did, and that was crazy. And just sort of that acknowledgement of, how insane the work we do can be. I think helps people. But when people think, wow, this is crazy, there must be something wrong with me. Everyone else is walking around like this is normal.
Yeah.
And
In their
you
head,
never know.
in their head, everyone's going the same thing. They're like, this place is nuts.
Right. And so, and for every person, there's going to be a different trigger. So, I mean, there's some days when everything is crazy, where the patients are, stacked in the rafters, where you're doing EKGs in the decon room because you have no other place to do anything private. Like, there's days that are crazy for everyone, and I think everyone gets that. But then when that one thing happens, when that patient codes and they just happen to look a little too much like your grandmother, or that guy you code has the same birthday as your husband, and there's just something about it that triggers you to think, wow, I'm not okay with this. We don't ever talk about that. And it's kind of surprising because I would have thought we would have gotten better about that. And I feel like we haven't yet. We haven't really come to a place. And I know some hospitals are doing good work with that, doing, the debriefing afterwards. And I'm happy that more organizations are really pushing debriefing after critical incidences, even if they're framing it more as a process improvement than a emotional support.
Even just that little bit of a little
advice my
decompression
mom ever gave me.
That turned out to work well for nursing.
Huh. That really stumped me. I'm really not sure that I could even think of the answer to that. My mom really always encouraged me to look for the best in people and to understand their side of the story with things. I remember as a kid, I was complaining about, something, teenage girls, there was always drama, like some slight that I had encountered from a friend, and said, well, what was your part in that? I'm like, well, no, it's not my fault. It's her fault. No, maybe it's your fault too. And I think that when you apply that to emergency nursing, you can really think about, again, trying to understand that patient's perspective of why did.
Yeah, I think that's certainly something you have to do as an emergency nurse, for sure.
Yeah, because I'm thinking putting a potato in the soup to get the salt out probably doesn't apply to emergency nursing. More usually concerned about trying to get salt into people than get salt out. But anyway.
Good point. That's a good point. Tell me about a patient that changed the way you practice.
Actually, for that, I'd have to say it was my mom. My mom was the patient. My mom has been dead 9 years now, and she had a chronic illness all her life. She had lupus, and we were in and out of the hospital on a very regular basis, particularly towards the end of her life. She was in and out, almost every 3 months, and, you kind of had a routine. Her last hospitalization at the beginning, I had no inkling that was her last hospitalization. She had gone into a hospital, and I observed nursing care that was really not okay. And I tried to, weigh the pros and cons because, everyone tells you don't be a nurse, be a daughter. But then when you see things that you're like, this is not safe. This is not safe for my mom. You have to speak up. And so I had seen a couple things, including a day she had chest pain, and the nurse came in and gave her some nitro and then sent her off the floor for a procedure within 5 minutes of giving her nitro. And I'm like,
that's,
like my, and she didn't have angina, by the way. So, and an EKG didn't happen in a timely manner. And of course, the end of the story, she had an MI, but that whole event was mishandled horribly by the floor nurse. Just like, and I kind of wondered, like, what were you thinking here? And so we had that experience, and then she got transferred out to a higher level of care because she got much, much sicker. And when she went to this higher level of care, they received her into the intensive care unit and started doing a bunch of tests. And I was asking, like, what are you doing? And I didn't expect to have an answer. I just wanted somebody to say, we're running X, Y, and Z tests. We're trying to narrow down our differential between this and this. Just something, some kind of information. And instead, they kind of patted me on the shoulder and said, no, don't you worry about it. We know what we're doing here. We're blah, blah, blah hospital. And I lost it. And I became that crazy person that you hear about screaming in the middle of the ICU, because all these other things had happened that had made me very distrustful of the healthcare system. And they were in there not wanting to tell me anything. And, I should just trust them that they know what they're doing, even though they're not telling me anything. I lost my mind. I really did. And I think this really informs how I approach patients who ask questions, who ask family members who ask questions, because in that moment, all I wanted was a little bit of information. I wasn't expecting the answer. I wasn't expecting a treatment plan. I just wanted to know, what tests are you running? And so now when I have a family member, you ever see the family member with the notebook who's writing everything down? How do you spell your name?
My gosh.
I'm like, I'll spell
Yes.
it for him. What are you doing? I'm giving morphine. It's 2 milligrams. It's the next, won't be able to have the next dose until 2:00. Like I probably over educate my patients now because of this. And because it was such an awful, awful experience on my end to be dismissed like that. And they knew I was a nurse too. That was even worse in my mind, because I was just so flabbergasted that they would be so cavalier. I'm like, this is the most important person in the world to me, and you're asking me to trust you without any relationship, without any evidence. And, I think that's something that we have to do all the time in the ER. We don't have the time that they have on the inpatient side of the house to build up those relationships and really get patients and families to know that you're a good practitioner, that you're safe, that you can be trusted. We have to establish those relationships really, really quickly. And the way we can do that is not being afraid when people ask us questions, not being uncomfortable. And I think part of that comes from my EMS background too. Like we would code people, on the kitchen floor, and we couldn't exactly say, you have to go to the living room. The living room is the waiting room, and you can't be here while we're coding your husband on the kitchen floor.
Like, this is my kitchen.
Right. So you get used to the families being there and asking you questions. And I'm okay with saying to somebody like, look, I'm trying to program this pump, and it's really a little complicated because, they reprogram something, and I just got to pay attention to what I'm doing, and then I'll be happy to answer your question. And everyone's fine with that. Everyone is fine with that, as long as you acknowledge that, yes, you have the right to the information. Throughout the course of my mom's hospitalization, the other thing that I found was there was a real difference in some of the nursing care. Some of the nurses were like, I don't want you here. I don't want you asking questions. Just go away and let me do my job. And other nurses were so wonderful. They made up the jury chair for me. They showed me things in the computer. They, would print out lab results for me. They would do everything. And the most meaningful thing to me was one night, it was like 2:00 in the morning, and one of the nurses comes to me and says, does your mom have any skin allergies or anything like that? I'm like, what are you talking about? She's like, I need to wash her up, and I was going to use this soap. And she had like a Bath and Body Works kind of soap, and it smelled really good. And she dispensed it into a little cup from the nurse's station, so there was no cross-contamination. But she used this like nice smelling soap instead of that hospital disinfectant smelling thing. And she really made me feel like she was caring for my mom. At that point, my mom was intubated. It wasn't looking very good, but she still treated her like a person. And I'll never forget that, at this point, I don't remember the nurse's name. I probably wouldn't recognize her if I bumped into her in the grocery store, but I've never forgotten how she made me feel that she really cared. So that's my story.
Wow. Boy, that hits close to home, huh?
I've actually used this story a lot to illustrate for people. I tell my students the story a couple times a year because I also talk about it in terms of family presence. Because after the whole not telling me what they were going to do, they said, "Well, we're gonna put a Shiley in. I think we have to dialyze her, and you have to go to the waiting room." And I'm like, "No, I'm not going to the waiting room." And we fought about it, and I did not want to go to the waiting room. I'm like, I will gown, I will glove, I will stand in the corner, I will not breathe, but I want to be here. And they refused. And during the course of the procedure, my mother, who is awake, alert, and talking, got intubated, and I never got to talk to her again.
Oh my gosh.
And her last words were, "I don't think I'm going to make it." And of course, I'm like, no, of course, Mom, you're going to be fine. It's just a quick thing. I love you. I'll see you in a few minutes. And the thing is, like, I understand they were putting in a big line. They could have, dropped a lung and, had to tube her. She, not tolerated the procedure. I'm okay with all of that. I'm an emergency room nurse. I would have been fine with that. But they were so intent on, no, you can't be here. I wouldn't leave. Like, I left the unit because they made me, but I didn't go to the waiting room. I stood right outside the unit doors. And it was an hour and a half later that they came out to tell me that they had to intubate her. And didn't offer me tissues, a chair, water, nothing, just left me there. So I'm sobbing in the middle of the hallway. And I'm like, this is nobody came to check on me and make sure that I was okay. They had no regard for me as the family member. And I'm like, this is no way to treat a person. I'm like, we would never let this happen in pediatrics, right? If it was a kid who was sick, you would never treat the mom like that. So why is it different when it's my mom and I'm the daughter? I had a longer relationship with my mom than I would with my daughter. So I kind of use this to inform the whole family presence discussion because it made such an impact on me, and it was so traumatic that I never, ever want to do that to a family member. And I'm not going to drag them into a resuscitation kicking and screaming, right? If they want to come in, they're going to come in, and I'm going to support them to do that. And I was lucky enough at one of my former institutions to be able to push through a policy that says, yes, families have the right to be there. And, sometimes the doctors are like, no, they don't. It's my patient. I'm like, no, it's not. You don't own that person. They belong to their family. And, families don't interfere with resuscitations. I think I've had one family member that I've ever had to pull out of a resuscitation. It was because she was crying so loudly we couldn't hear ourselves think, right? But 9 times out of 10, if you bring a family into a resuscitation, they're going to stand in the corner up against the wall. They don't want to touch anything. They don't want to get in the way. They want us to do our job. But that transition between life and death, whatever your personal belief system is, most people believe that transition between life and death is a sacred space. And they want to be there when somebody transitions. And so how do we as nurses, how do we facilitate that so that they can understand what they're seeing? We've all coded the, 110-year-old patient with cancer, and you're all like, oh my God, why is this patient a full code? Why did they not put them in hospice and let them die, peacefully? When you bring families in there, they call those codes right away. They see it. They see how traumatic it is.
Yeah, they're like,
and they
knock
also
that
see
off. Let's stop.
Right. They also see how hard we're working, so I think it just makes such a difference to engage with families and with patients and just respect where people are as individuals. I'm sorry, you got me on my soapbox. I could go on this one forever because it's, it's really personal to me. And I think it's important to tell these stories personally. It's not some, random policy. This was my mom.
Yeah.
That
really brings it home when you tell the story from, I'm not going to tell you about a time that I was on, but a better way, there's no better way to impact somebody's practice than to make it that real.
Absolutely.
So I agree 100%. I think that's a great way to teach a lesson. So it's a great way to teach a lesson. The last question I ask all my guests, you've heard it before, It's called Three Things. I'm going to ask you to give me 3 things an emergency nurse should remember and 3 things that they can just go ahead and forget.
I think the first one is always remember to assess your patients. And particularly when working with new nurses and the critical patient, that patient who comes in and, crumps right away and gets tubed or whatever, everyone's always very task oriented and they forget to do, basic assessment stuff. And so I'm constantly on the nurses to do an assessment. The very first thing you should do with the patient is some form of assessment. Even if it's just like poking your head in. Hey, you got a lot of information just poking your head in. You know what the patient looks like. You see that they're awake, alert, and oriented. Their skin color is good. Their breathing is not labored. You have a baseline to know what you're doing. But a lot of people get wrapped up in the I'm going to do a task because a task is sometimes a lot easier than doing an assessment.
Absolutely.
So that's one thing I'm very big on. And I think the other 2 are the things that we've talked about already, treating people like people and not forgetting patient safety things that you learn, sort of the nursing 101 pieces of do the things that we need to do to keep your patients safe. Nurses are the last line of defense, and the ER is such a chaotic environment. You can't forget to do things like identify your patients, check your wristbands, make sure they put slipper socks on before you stand them up. They're the basic things that you're like, but they really are basics for a reason. And I think sometimes people get into that mindset that they're too cool and they don't need to worry about that, and I got it all together. And the more chaotic the environment gets, the more you need to slow down and pay attention to make sure that you're being safe at what you're doing and you're keeping your patients safe. To me, that's the most important thing. Every time I go into work, I have like a little affirmation prayer thing that I go through, make this a good shift, keep me safe, keep my coworkers safe, and most of all, keep the patient safe. And, make my IVs go in straight. But, really like pay attention to those patient safety factors.
Yeah, absolutely.
The things that you can forget, I guess, forget outdated practices, forget this idea that you know everything. Every day I go into work, I learn something new. A new drug, a new procedure, a new policy, something. There's always something new to learn. So if you think, oh, I've achieved, I got licensed, or I landed the job I wanted, or I finished my BSN, I'm done learning. You are not. So forget that idea that you know it all, because nobody knows it all. And forget the idea that anyone is beneath you. The people that work on your team are the hardest working people you've got. Whether they're your techs, their unit secretaries, housekeeping. Think about your housekeepers. Do you know the name of your housekeeper? Do you know who to ask for X, Y, and Z? Because they're out there humping right along with you, and just because they don't have an advanced credential means they're any less important to the healthcare team. And I think sometimes people forget that piece. That everyone has an important role to play. So, forget the idea that you're more important than anyone else.
Like that. We used to tell people all the time, we'd make sure to introduce them to our housekeepers, because our housekeepers were an incredibly important part of our staff. They're the ones who determine the flow. The housekeeper does. Well, the housekeeper does, because the housekeeper is going to either turn over the room fast or not turn over the room fast.
Right.
If you need something, a stat clean, you need it cleaned right now. You can't say, "Hey, you, ma'am, well, come get this fixed." When it's easier when you can just go out and be like, "Hey,
I think
hey, Norma, come get this done."
Well, I think one of the things when I was on orientation in my first job, I thought my preceptor was mean and evil because she wouldn't let me ask the techs to do anything. I couldn't ask a tech to toilet a patient. I couldn't ask a tech to do an EKG for me. I had to do it all myself. And in retrospect, she was brilliant. At the time, I thought she was like, oh, my God, this woman hates me, right? But guess what? I know how to do all of it. I know how to do my own EKGs. I know how to do almost everything that needs to get done. Because guess what? There are days you go in that you don't have a tech, or all your techs are pulled to one-to-ones, or something. And I'm flabbergasted at the number of nurses who sit there and go, "Well, I don't know how to do that." You should learn, number one, but don't ever think that you're too good to do somebody else's job. I make beds, I empty garbage, whatever needs to get done to keep our department running. That's what you need to do. And if everyone had that mindset, I think a lot of departments might run a little more efficiently.
One of the things that always impressed me, I used to work for a guy named Mike, and I remember Mike was I think he was the executive director at the time. And one day I'd look out in the lobby, in the ER lobby, and he's out there with a mop bucket mopping up a spill. And here he is in like an expensive 3-piece suit, and he's out there mopping the floor. And I'm like, dude, what are you doing? And he goes, well, I'm mopping the floor. There was a spill, and I was like, there's about 50 people in the department who are all below you, who could easily do that for you. And he's like, hey man, I sling a mop too. I know how to do that. And I was always like, okay, that's the kind of boss I want to work for. That's the guy.
Exactly.
He's the guy that I want to work for. And one of the things that I always remembered, and one time we were super busy. We were really busy in the trauma room. We were getting killed. And the CNO, and he was the same guy was the assistant CNO at the time, and they both came down to the trauma room and they said, what can we do to help? And the CNO was like, I'm probably not super helpful to you, but by golly, I can transport your patients upstairs. I'm like, great, you're a transporter. Go do that. And then the assistant CNO, who was very skilled, a tremendous ER nurse, I go, I need you to go in that room and be an ER tech. I don't have an ER tech. Go be a tech. So he tucks his tie into his dress shirt and he goes in there and he's like, I'm here to be your tech. And the nurse comes out and goes, Kevin, you sent the assistant CNO to be my tech? And I'm like, yeah, treat him like a tech. I would have him do everything the tech would do. She's like, does he know how to do that stuff? And I'm like, he does. He'll be fine. I go, treat him exactly like a tech and he'll do everything you ask. And sure enough, he did. He was a tech for us for like the next hour while we were, cranking through some traumas. And I just remember thinking to myself, and if he hears this, his head will swell. But I'm like, he's the man. That's the kind of guy I want to work for. And
absolutely.
He was a mentor to me in a lot of ways, and that was the lead by example. So
I have a quote that I keep on my desk to kind of remind myself. Leadership is not about being in charge. Leadership is about taking care of those in your charge.
Absolutely.
Whatever they need, try to get them what they need, even if it means being an ER tech or slinging them up. I love that story.
Yeah,
that's great.
Yeah. So he's the guy. You'll remember him. Remember the guy? Remember the picture of the apron? The guy that took the picture?
Yes.
That was him.
Oh, okay. I got to find that picture. I know I've got it somewhere in my timeline.
That I looked for it and I couldn't find it. So that was
too funny.
Funny. Good times at the ENA conference, right?
Yes, absolutely. Well, I hate to cut you off, but I really got to run to this other meeting.
Yeah.
But this has been a ton of fun.
This has been a lot of fun.
Chatting.
It's been a lot of fun. And we'll do it again, I'm sure, at some point for something else. And I want to just say thank you so much for spending the time to talk to me today. I really appreciate it.
Thanks for having me. It's been my pleasure.
Thanks for listening to the Art of Emergency Nursing podcast. Make sure to subscribe to the podcast and follow us on Facebook.